Well, thank you so much for the incredibly kind invitation to be here. And I marvel at Daphne and Ben and just the way they can bring together humanity and science. And I hope that my talk will provoke some conversations, some thoughts in you all. It's going to be a total smorgasbord of ideas, but the challenge for me lies that despite being in this field for a long time, this is data that's been merged between Australia and the NRN, we have not made the impact that we would like to have made in terms of neurodevelopmental outcomes. And this is 20-year data looking at improvement in survivals of very low birth weight infants and some trends towards reductions in cerebral palsy, but no apparent improvements in neurodevelopmental outcomes. And why is that? Well, part of it is that despite everything we are doing, one of our major forms of brain injury, intraventricular hemorrhage, persists almost at exactly the same rates, and this is rates from the Vermont Oxford in the last 5 years, that are unchanged. And why is that? This is a very busy slide, and I don't expect you, Joe Volpe and I spent a lot of time trying to put this together. But really thinking about IVH as an ischemic reperfusion injury and the important sort of collaboration of cardiorespiratory physiology and the way we respond with limited information, because most of the time we don't have visibility on all of these dimensions such as cerebral autoregulation and cerebral perfusion and other things that we need. And so what kinds of things could we be doing? Well, one of the things we could be doing about is, at least if we have intraventricular hemorrhage, is to think about one of the very adverse consequences. And this data that came from a trial that took 10 years to undertake, looking at early versus late ventricular drainage in children with post-hemorrhagic ventricular dilatation, clearly showed that, at least in the European interventions, that there was a trend towards early intervention making a significant impact in terms of reducing the number of children with significant cognitive impairment in that bottom row. But what I want you to be aware of is, even though this trial might not have seemed to you startling in terms of a major impact, the problem is the Europeans had already moved to intervening at a much earlier time point than what is standard in the North American setting. And if you look at where those two trials were intervening on ventricular measurements, which I hope you are all doing routinely of your ventricles in any baby with intraventricular hemorrhage or intraventricular blood, and please do them in so-called grade 2s as well as grade 3s, because the accuracy of whether it's grade 2 or grade 3, anybody with a lot of intraventricular blood should have these standard measurements being done on cranial ultrasound. And what the Europeans were moving the needle on between their early and late trials were down here. And this was data we collected looking at the relationship between how big the ventricles were and how poorly you did 2 years later. And obviously, the bigger your ventricles got, the more poorly you did. And this was what the Europeans moved this needle a tiny bit. But the hydrocephalus network in North America has clearly established that where we currently sit in terms of where most North American sites are seeking intervention on is way out here. So when you get referred your babies with post-hemorrhagic ventricular dilatation for treatment, many times they are already profoundly dilated and already the die has been cast. So that was the goal of a paper that was written back now nearly 4 years ago as to how and when to intervene. And so you can access this paper. It has access to these charts that have post-menstrual age adjusted measurements for zones of safety related to the measurements that you're going to be taking with your radiologists on the ultrasounds. And it also gives you guidance as to what to do when you are in those zones. So if you're in the healthy green zone, orange zone, or red zone. And so this is something you can be doing today, making sure those measurements are done in all your children, making sure you're plotting them and knowing when to intervene, and following these guidelines to intervene appropriately, whether initially just with a couple of lumbar punctures to see if there is persisting enlargement of the ventricles or not. But it will make a difference. What else can you be doing in terms of these brain injuries? There's been a number of things that have been trialed, but perhaps one of the simplest that has been shown to be effective was a nursing intervention bundle. And in fact, many of you are familiar with these in terms of the head position in the incubator and not touching the baby too much in the first 72 hours. But the one we don't pay much attention to is this one of rapid intravenous or arterial withdrawing or flushing of lines. And in fact, I didn't really pay that much attention to this. This is an intervention that was given in the first 72 hours of life and continued afterwards. But if you think about it, for a blood draw, and I love getting lines in fast and getting my labs away and getting my hands off the baby so we can complete the magic golden hour, but this has made me pause. So let's take our premature baby of 500 grams with a blood volume of about 50 mils compared to us. Let's take our standard blood draw just after our lines are in, which is about 5% of their blood volume. Compared to what it would be for us, that's about 250 mils. So that would be like drawing back a whole blood donor pack in about a minute. And I think if any of us went and somebody tried to take our blood that fast, we would be a little bit upset and we might feel pretty lightheaded. And that's with intact cerebral autoregulation, which many of our babies don't have. And so what this intervention did was it actually put a stopwatch, simplest of AI, right? A stopwatch by the bedside and said, and I've started doing this myself. I look at the clock now, and I was shocked at how I was drawing back in like 5 seconds because I was just, bang, bang, bang. And so this is something incredibly simple. What this intervention showed was this size reduction in IVH. Of course, we can get more information, and I think the era of modern hemodynamics partnering with neonatology is definitely here to try and remove some of the diagnostic uncertainty. And that's certainly been shown by Patrick McNamara's elegant work that really brings in algorithms for how to evaluate these babies, and with those algorithms showing dramatic reductions compared to historical controls in the rates of high-grade IVH. So these things have been shown to make a difference, whether it is as simple as just drawing back on our lines and flushing our lines a lot more slowly, or more sophisticated ways where we can diagnostically know what we are actually treating and managing and tailoring our treatments. But let's say we've got in the situation of having IVH or having a parenchymal injury, and we want to be able to make a difference then. Are there things that have been studied that we know make a difference? And I am a huge believer in rehabilitation and the importance of how that can modify outcomes. And this is the latest of the Cochrane reviews, which was just published, showing the impact of these early developmental intervention programs. Importantly, in this Cochrane review, it shows that the most powerful intervention programs were the ones started in the NICU. And this is something we often don't advocate for. We see therapists around, sometimes we talk to them, sometimes we have conversations about the care plan, but we don't value it the same way we do other types of interventions. And yet when you look at beautiful work like that done of Vittorio Gallo, looking in a scientific way at how the interventions made a difference to not just functional outcomes here in the behavioral column, but also cellular outcomes. You can see that when it was started early in relationship to the injury, and it was continuous, i.e. within the neonatal unit and continuous after discharge, that's when the difference was most seen. And how much attention do we pay to that? I don't think we pay very much attention to it, and I don't think we very much actively advocate for it. And this is shown by even more beautiful data that's shown on follow-up from the Peanut trial, which looked at these very high-risk infants, and I know this is hard to see on these slides, but these are less than 28-week infants who were being followed up very carefully by the Peanut group for their neurodevelopmental outcomes, and they were just recording what kinds of therapy groups they were getting access to in the community. So remember, these are all high-risk babies less than 28 weeks in the United States, And they would all, theoretically, I hear all the time, but they'll all get access to early intervention and therapies. And as you can see here, between 40 to 70% only of these children were getting any services by the end of the first year of their time after the neonatal intensive care unit. So a huge number of these children, and we could spend a lot of time talking about the inequities, which are even more accelerated in that. So injury is one side of the equation. The other side of the equation perhaps is even more important, and that's what's happening to the preterm brain irrespective of injury. And we've long noted this pattern of brain dysmaturation that's more global, particularly affecting the hippocampus, the amygdala, and the temporal lobe. And when we compared 54 preterm infants in St. Louis that had no evidence of brain injury to 24 healthy term-born controls, at the time they were going home from the hospital, and took their brains and compared them, the area that lit up as being very different was the temporal lobe, and in particular along the superior temporal sulcus. This is an area that is very vulnerable and very affected by the difference of being born prematurely and cared for in the neonatal intensive care unit. And it doesn't get better over time. And this is particularly concerning to us because we see this change with development. This is the same cohort that has been followed by us in Australia now, and we've just finishing our 21-year analysis. And you can see the difference in the temporal lobes between the term and the preterms is getting bigger. And the problem with this is the first area of the brain that's vulnerable to aging. And so we are setting them up from the time they leave the neonatal intensive care unit for the rest of their lives. And what happens in the neonatal intensive care unit is going to affect them for the rest of their life. So what is happening? Well, we started studying this with a medical student way back in WashU, and as many are familiar, we found that despite every medical factor we looked at, it wasn't the medical factors, it was actually the amount of stress the babies were experiencing using this neonatal infant stressor scale that was developed with our nursing staff. And indeed, this was what made the frontal and temporal lobes so vulnerable. So what else does that mean? It means there are things that we could be doing that might reduce stress. And obviously, people here are huge advocates for skin-to-skin care. And there's been wonderful studies, this one out of Israel, looking at the impact not just short-term of 1 hour each day for 14 days, but also up to 10 years of life. So how are we going? Now, the Swedish recently published this article because they felt they had a big opportunity to improve. And they published it to highlight the gap between what they wanted and what was actually happening in their cohort over a 1-year period. And they looked at their 22 to 24 weekers and looked at the median time for first skin-to-skin as 4 days. 4 days after birth. That was too long for them. I would challenge any of us to put our hands up if we are getting skin-to-skin care in under 3 days in our 22 to 24 weekers. Their 28 to 32 weekers, 75% of them got it within the first 24 hours. And in the first 7 days, they averaged 3 hours a day. And over the whole NICU stay, it was 6 hours a day. So they really published this because they said it wasn't good enough. And I would challenge us to think about that in our own context. We looked at the environment in more detail when we compared at WashU single-family rooms versus open bay, thinking the single-family room was going to be the answer because it would take away some of that stress of the loud train-like station environment and be able to put our babies in a quieter Hilton-like place. And in fact, we found the opposite. We found that the babies that were cared for in the single family room on our follow-up 2 years later after controlling for many factors had worse outcomes, particularly related to language. They had an 8 IQ point deficit, which has persisted. And when we looked at their brains, what we found was that the language asymmetry that is typical in a term-born infant, in the same way it's in our brains as adults, which is crazy, that they are all set up to have language in place, was not present in the single-family rooms, whereas it was present in the open bay. We have a huge deficit in terms of the experience our babies are having, and this was a beautiful paper published by a postdoc who's now a faculty member. And he looked at the difference between fetal life and a neonatal intensive care unit that's actually open bay, and looked at the number of words that a premature baby in our environment is exposed to compared to a fetus with a mother carrying the Lena device around. And on average, most women are exposing their babies to about 2.5 to 3 hours of language a day, whereas a preterm infant's getting less than 20 minutes of language exposure a day. I can tell you we just did CHOC, and it's about 8 minutes of language exposure a day. They're getting much more electronic sound and much more adverse airborne noises. So the room environment, I'm not going to say it's all bad, because there's some data that's been meta-analyzed to show not big differences, but it's not the room type that matters, it's who's in the room. And that is the key message I really want you to go away with. We know, and others have studied as well as us, on average our parents are present for around 2 hours a day, and that there are associations between parent presence and long-term outcome. And indeed our environment at the moment, we've forgotten. It's really very set up for the wrong things. We need to first of all appreciate how much the environment influences brain development in many regions. It's clear noxious things are bad, but it's not just that. We have a complete absence of nurturing and enriching exposures. We don't even record or monitor how many hours our families are present, how many days the babies are held, how many experiences they're getting when we walk into a room. And in fact, I have heard our nurseries deemed by other people who have walked in sometimes as glorified orphanages. Do we think like that? No, because we've lost the capacity to see it. We've been in it too long. And we have to take those glasses off and put the others back on. And with that, that's why I love being in these kinds of think tank pod places with bright minds like yours in the future of the field, because at the end of the day, this is why we are here, because we want to be able to turn things for the future into something brighter. Thanks so much for your time.